not a whole lot of EKG. Just remember the definitions of EKG. Don't expect a lot of EKG strips. If any, will be stuff like axes and stuff like that. But be very familiar with the definitions on the EKG lecture. I want to make sure we're clear on that. So, remember that on the EKG, you have the 12 leads, and you always have a rhythm strip. There is a reason you have a rhythm strip, because we do EKG for two reasons. One is to look at the electrical activity of the heart, and also to look at the rhythm of the heart. The rhythm of the heart is a whole section in cardiology, because there are diseases that manifest only as rhythm and rate disturbances. And then EKG abnormalities are a separate group of clinical, whatever you call it. We use EKG to investigate the heart. We use rhythm strip to evaluate abnormal rhythm. So there are two separate sections. So today, we're going to talk about rate and rhythm disorders. That is half of what we talked about last week. When we talk about EKG, it's in the summer. EKG strip itself is in the summer. So right now, we're going to talk about the rhythm strips and everything that could go wrong, how you could evaluate what is going on with the rhythm. For the treatment of the rhythm, I will touch on them briefly, but you will deal with them in depth when you do your ACLS. Okay? All right, so let's go. Let's get some definitions straight. So heart rate and rhythm disorders, they frequently coexist. Okay? But they may occur independently of one another. A normal heart rate does not necessarily exclude the presence of a rhythm disorder. So if just because somebody has a normal heart rate does not mean they can't have a rhythm disorder. Okay? And many rhythm disorders are not associated with heart rate disturbances. So you have to understand that rate and rhythm are different characteristics. You cannot make any assumption on rhythm based on rate. And you cannot make any assumption on rate based on rhythm. You have to look at them independently. So when you look at, I'm going to teach you this morning, when you look at that rhythm strip, be very clear in your mind what the rate is and what the rhythm is. Don't fall into the trap of saying, because the rate is 60 to 100, then it's got to be normal rhythm. No, that's not true. Many abnormal rhythm will have normal rate. Okay? So make sure that rate and rhythm are separate in your mind. You look for them independently. And many, many times what you will understand at the end of this lecture is that you use rate information to validate our impression on rhythm. And we use rhythm information to validate our impression of the rate. Okay, so they are not synonymous. They are very separate characteristics. Now, in practice, you hear people talk about arrhythmia and dysrhythmia. Well, it's preference. It depends on how you're trained, where you're trained, whether you're British trained, American trained, whatever trained. I just think you should know. Arrhythmia just means absence of normal rhythm. Okay, so the A there is absence of normal rhythm. Dysrhythmia means presence of abnormal rhythm. They are synonymous. Okay, arrhythmia, and if you have absence of normal rhythm, that means you have presence of abnormal rhythm, right? If you have presence of abnormal rhythm, that means you have absence of normal rhythm. Okay, so it depends on what you want to describe. Because arrhythmia or dysrhythmia does not matter. You've seen this slide before. Now, and it's a picture. Now, you look at this. Remember I told you that the SA node is the pacemaker of the heart. The reason the SA node is the pacemaker of the heart is because it has the highest intrinsic rate. Okay? Whatever pacemaker has the highest intrinsic rate becomes the dominant pacemaker of the heart. So the SA node set the rate and the rhythm of the heart at any given time because it has this highest intrinsic rate. If you have SA node disease and something happens to the SA node, and SA node loses dominant, the AV node will take over. Remember, the atrial tissue does not have inherent rate, okay, because there are two tissues in the heart, electrical and mechanical tissue. The atria are mechanical tissues, okay? Then the AV node, on this table, even though it says AV node, bundle of His and bundle branches, all together, it's difficult to tell from an EKG whether the AV node or the bundle branch is the pacemaker. So generally we just talk about nodal rhythm, and we generally talk about it as 20 to 40. Okay, so you say it's a junctional rhythm at about 20 to 40. Sorry, 40 to 60, 40 to 60, 40 to 60. Correct these numbers on this table. I like this diagram, but I didn't really like the numbering of it. It's 60 to 100 normal sinus rhythm, 40 to 60 junctional, and less than 40 idioventricular. Okay? Right, so that's what I want you to remember. So 60 to 100 is normal sinus rhythm. If anything happens to the SA node and the AV node takes over, whether it comes from the AV node or the bundle of His or the bundle branch, we call them together, and generally it's from 40 to 60, okay, junctional rhythm. And then once it's less than 40, most of the time, it's usually from the Purkinje fibers, okay? Okay, just remember those numbers, 60 to 100, 40 to 60, less than 40, okay? So, this is a normal sinus rhythm. What makes it a normal sinus rhythm is because this is the rhythm you get when the SA node is the dominant pacemaker. Okay? The SA node overrides and suppresses all other foci below it. Why is it normal sinus rhythm? One, because the rate is 60 to 100. Okay? And secondly, because the rhythm is regular. It's a regular rhythm. That means the interval between the QRS complex is constant, barring the sinus arrhythmia. Okay? That also means that the way you can say that this is from the SA node is that there is a P, a QRS, and a T in every complex. Okay? Not only is there P, QRS, and a T, the P is identical in all the complexes. The QRS is identical in all the complexes in every single lead. Okay? It doesn't have, the P does not have to be the same in lead 1 and lead 3. But within lead 1, the P must be the same. Within lead 3, the P must be the same. Between V1, the P must be the same. But it doesn't have to be the same across leads. But within lead, it's got to be the same. So when we say, you look at an EKG, and from a casual glance, you can see that it's regular. Every complex has a PQRST, and the P and the QRS and the T are similar in any one lead. Most of the time, when you're talking about rhythm disorder, you only have one lead, either lead 2 or V1, depending on how the MA sets it up. And then the PR interval is always at 0.12 to 20 milliseconds, and the QRS duration is less than 0.12 milliseconds. But remember, I just told you that PR interval, generally the beginning of P to the beginning of QRS is generally one big box. If it's more than one big box, which is 0.20, something is wrong, right? And the QRS duration is always less than 3 small squares, okay? So I don't like talking in terms of 0.12, 0. Just talk in terms of squares, because that's what the EKG will show you. It won't show you time. Okay? Are you with me? Excellent. The SA node is under the control of the autonomic nervous system. Okay? And you need to know what the autonomic nervous system does to the SA node. The parasympathetic innervation inhibits the pacemaker. activity of all the cardiac automaticity foci, with the exception of the ventricular foci. So remember in autonomic nervous system, when we talk about pharmacology, we talk about the sympathetic nervous system accelerating the heart rate and the parasympathetic reducing the heart rate. All of that is only above the ventricle. The autonomic nervous system does not interfere with inherent ventricular rhythms. That is extremely important for you to know. And that is protective, because some people, their heart will slow down or even stop if they get bad news, and the SA node could be taken out, but they will not die because the ventricle is immune, insulated, protected from that autonomic influence. That is, you begin to understand that. You will understand that more when we go to, as we continue in this lecture. Okay, so inherent pacemaker, see what sympathetic does, see what parasympathetic does to the inherent rates of the heart. So, you've seen this slide before, and I don't know why I keep forgetting to fix this error. Anyway, this is a new lecture. Please change this to non-dihydropyridines, okay? Because the dihydropyridines are the Norvasc, the felodipine. The non-dihydropyridines are the ones that you don't want to combine with beta blockers, okay? Diltiazem and verapamil. So you've seen this slide before. These are the causes of bradycardia, okay? Under the causes of bradycardia, you have all these extracardiac issues, intracranial hypertension. If somebody has intracranial hypertension, that is obvious. They have head trauma, they have a stroke, something is going on, it's an acute thing. You don't need to figure it out, you know it, okay? When somebody has intraocular hypertension, like in glaucoma and hemorrhage, they come with a history, okay? So you don't need to, you will see bradycardia and you'll be able to associate it immediately, okay? If somebody has hypothyroidism or obstructive jaundice, or they're undergoing a vergotonic procedure, like I explained to you, or they have athletic conditioning, these are things that clinically, if you take a good history, it's obvious, okay? Somebody's on beta blocker, or they have overdose of digoxin, or they are on non-dihydropyridines, calcium blockers, history is obvious. What you need to figure out is heart block, SA node, and AV node block, because those are causes of bradycardia that you have to figure out on the radial strip. Okay, all these other ones, they will see you will see bradycardia, but it's always going to be sinus bradycardia. Okay, when it is due to sinus SA nodal block or AV nodal block, you have to learn to figure that out on the EKG. So my subsequent slides are going to talk about SA nodal block and AV nodal block. So now let's go. When there is bradycardia as a result of SA nodal disease, there are two main causes. There is an SA nodal block, or there is a sinus arrest. In SA nodal block, the inherent automaticity of the SA node is preserved. So the SA node is firing like it should, but the electrical impulse are not able to leave the SA node, so they are getting blocked. Okay. In sinus arrest, the SA node is failing to generate the impulse. Let me paint a pathophysiologic picture for you. If something happens to a coronary blood supply of the SA node, and the SA node itself is not getting enough blood supply, it will begin to fail in its ability to generate impulse. That will give you sinus arrest. But say somebody had sarcoidosis, and a granuloma is sitting right next to the SA node, causing scarring around the SA node. The SA node is generating the impulse, but the scar tissue will not let the impulse leave the SA node to excite the atrial tissue. You call that the SA block. How do you tell it apart on the EKG? The way you know the difference between sinus SA block and sinus arrest is you look at the pulse. Usually the way both of them will present is a pulse. So you have an EKG, and you always got, imagine this is all the way there is, right? You always got that. So what you will see is a long pulse. The tricky part is when you see that long pulse, this complex must be exactly the same as this complex for you to say there is this SA node. Remember, it's an SA node problem. It is a block or an arrest if the complex before the pulse and the complex after the pulse are exactly the same. If they are not the same, take a step back. You could be dealing with something else. Very important point, and it will become clearer to you. So both SA nodal block and sinus arrest present with a long pulse. How then do you know when it is SA nodal block versus sinus arrest? Usually, when it is a block, because the inherent automaticity of the SA node is preserved, the pulse is usually multiples of the RR interval. Okay? In other words, from here to here will be some kind of a multiple of this. Okay? You understand what I'm saying? So it's either going to be usually 2 or 3 times that. Okay? So that's what I mean by the pulse is multiple of the RR intervals. Whereas when it is sinus arrest, it is not a multiple of it. So in other words, if you measure the gap, it will be less than any multiple of the RR interval. I think I have a very practical. Look at this. So this is a rhythm strip, right? See? The complexes are identical. They're coming from the SA node, right? And then all of a sudden there is nothing happened. And then this complex appeared. Because this complex and this complex are identical, we know this is either a sinus arrest or an SA nodal block. So what you now do is you measure from here to here. Roughly, this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, a little over 12. And this is, let me take, okay, 1, 2, 3, 4. Is that a multiple?
Yeah.
No. See.
I said 4 and 12.
Is 2 multiple of 2RR. Multiple of 2RR. So it's going to be 2, 4, 8. You understand that?
Would have to be 6, right? As if you multiples of 2.
Do you have this strip?
Yeah.
Okay, to start with, get a piece of paper. Get a piece of paper and put the paper under this right here. Give me one. Can I take one here? Put it right under there. And mark on your paper, draw a line that corresponds to those two. Right? And now, once you've done that, I want you to match that paper across this and see whether you land precisely on these two. When you match the paper,
It doesn't. Don't tell it.
is it a multiple of it? Is it 2 or 4 of it? Thank you. That's exactly what I'm saying. What I'm saying to you is that when it is a sinus arrest, this interval is not multiple of the 2RR. So you have to take 2RR like this and match it. So this interval will be either twice this or 3 this, but it will be multiple of the 2RR intervals. Okay? So if you go over here now and we do this a lot, you match this and this, they will match. If you begin to match, to walk that paper across here, you find out that the distance between this and this is less than 2RR interval. That tells you that is what makes this, that is what makes this a sinus arrest. Okay? But let's do the same thing with this. Use your paper again. You can use another end of it and mark these two out and these two and match it across. You will see that the gap between this complex and this complex falls right on top of that. That is a multiple of the RR interval. Okay? So when it is a multiple like that, you say it's a block. That means if it is precisely the multiple of the RR interval, that means the inherent automaticity of the SA node is preserved. In other words, the SA node is firing. But not all the impulses are they're getting blocked. Whereas when it's sinus arrest, it's not multiple of it because the SA node is failing. The inherent automaticity is not preserved. Okay, you got that?
Yes.
Everybody clear on that? Excellent. Second degree SA block, we'll get there, but right now I just want you to be able to differentiate sinus arrest from sinus block. Remember, the block is multiple of the RR. Okay? You're good? All right. So let's go now to the AV block. So that's all there is about SA nodal block. There are 2 sinus bradycardia as a result of SA nodal disease. It's either sinus arrest or SA nodal block. And the way you tell them apart is the gap. Why is it important that you recognize, before you measure this gap, make sure that the beginning complex and the final complex are the same? Why is that important? The reason that, say it again.
I was going to say to make sure that there's nothing else going on.
Exactly. The reason that is important, in addition to what David said, is that this is only a valid measure for as long as this complex and this complex came from the SA node. If an ectopic fills the gap and you measure it without recognizing that this is an ectopic bit, you'll be diagnosing somebody with a block that they don't really have. You understand what I'm saying? The only reason this measure is valid is because this complex and this complex came from the same place, right? So if this was an ectopic this configuration will be different from this configuration. You then cannot measure the gap between this and this. Okay? You're good? Right? All right, okay. So let's talk about AV nodal block. There are three types of AV nodal block. There is first degree, second degree, and there is third degree. In a first degree AV block, usually you don't have symptom. The patient is symptomless. But when you do their EKG, you only find a prolonged PR interval. The PR interval is prolonged, but every P is conducted. So there is no excess P wave. Every P wave gets conducted and attached to a QRST complex. So the P to QRS ratio is in every cycle is 1:1. Here there is prolonged PR interval because it's taking a little longer. So it's the earliest, is the mildest form of AV block, the first degree. Yes, the conduction is taking longer. The AV node is having difficulty, but somehow it's able to conduct every single P wave it gets across. It's able to transmit every impulse it gets across. And the only sign you have of it is prolonged PR interval. So when you look at the PR interval, it will be more than 1 big box. Right? Now, in second degree AV block, the impairment has gone a little worse. It's gone a little worse because some of the P waves now are not getting conducted. It's dropping P waves. So when you look at the EKG, you will see excess P waves. P waves that are not conducted. P waves that are not followed by QRS complex. So that is the sine qua non of second degree AV block. That is the pathognomonic feature of second degree AV block. There are unconducted P waves. But there are two types of second degree. Remember that. Two types of second degree AV block. There is the Wenckebach type and there is the Mobius type. The reason we differentiate between them is that one of them is really benign, may not kill your patient, while the other one is malignant, it could kill your patient. So it's not enough to say somebody has a second degree AV block. No, you must say this is second degree AV block Wenckebach, a second degree AV block Mobius. Because Wenckebach is benign, Mobius is malignant. Okay? So how do you tell them apart? In Wenckebach, there is a progressive prolongation of the PR interval prior to the P wave blockade. We talked about this a little bit last week. You remember? Yeah. In Wenckebach type of second degree AV block, the PR interval is long to start with, but it begins to get longer, and finally the P wave is not conducted. So second degree AV blocks by definition must have excess P wave. Wenckebach or type 1 second degree AV block must have variable PR interval. Specifically, the PR interval prolongs prior to the block of the P wave. Whereas in Mobius, which is the malignant type, there is no PR abnormality. The PR interval, in fact, is usually normal, but then the P wave gets blocked. And if you look in terms of pathophysiology, in Wenckebach, the problem is usually at the AV node, whereas in Mobius, it is usually below the AV node. It could be in the bundle of His, it could be in the bundle branches, but definitely below the AV node. Okay? In third degree, there is complete dissociation of the atrial activity and ventricular activity. So when you look at the EKG, the P wave are doing their own thing, the QRS are doing their own thing. They are not together. Okay. Now, let me give you a quick tip on how you can easily recognize, because remember, in both second degree and third degree, when you look at the complex, you will see that the PR interval is varying. Okay? If you look at the PR interval, and you could tell that it goes from long to very long, and it drops the P wave, and you could see the rhythm repeat, you know you're dealing with Wenckebach type 2, right? Second degree, Wenckebach, second degree. Now, but if you look at the PR interval, and it's long here, it's short here, it's very long here, very short there, and it's not, there is no rhythm to it, then you know this is most likely AV dissociation. So what you now do is you now take your paper and you identify two P waves and you match the paper across the rhythm strip. And you will see that the P waves are consistent, but they are not related to the QRS. And then you do the same thing for the QRS. You see the QRS have their own rhythm. That tells you they are operating independent of each other. That is why third degree AV block is also known as atrioventricular dissociation. Okay? You know, it's like a couple, right? When a husband and a wife are having trouble, the first thing they do is they stop talking. Right? That is first degree. The second degree is when they go out. A couple that would normally hold hands and embrace, they now have little distance. That's how you know when they're having trouble. That's how my mom used to tell when my sister had a problem that time. She comes in and three minutes later the husband walks in. Right? But usually before they walk in together with all this noise, when they make a lot of noise with their kids, whenever they walk in independently, then there is problem. When you now see my sister comes and her husband does not come, that is third degree right there. Okay. So they're all severity of the same kind of condition. Okay. But this is what the concept is. Let's see how it really plays out. So look at the first degree AV block, right? See the PR interval? Right? The problem is in the AV node, remember. PR interval is 0.28. What should it be? Less than 0.2, one big box, right? So that is how it looks. Look at second degree, Wenckebach type. Look at the PR interval over here. Right? Look at the PR interval over here. Look at the PR interval over here. And then see what happened? That P wave did not even get conducted. There is this prolongation of the PR interval from 0.18 to 0.25, and ultimately it gets dropped. Look at Mobius. Mobius type 2, second degree. See what happened? It's conducted, and boom, it gets dropped. There is no warning. At least in Wenckebach, you have warning of prolonged PR interval that warns you that that P wave is about to get dropped. But in Mobius, there is no warning. Okay, so you get a P wave, and notice that the PR interval is pretty consistent in Mobius. It just happened, boom. And then look at third degree. The P, and the T, and the RR wave are independent. They have different rates, and they're all just doing their own thing. I have a note here I want you to pay attention to. In Mobius type 2 AV block, the P wave is normal and punctual in every PQRS cycle. The P wave is normal and punctual. It comes when it's supposed to come. PR interval is fine. The normality and punctuality of the blocked P wave distinguishes it from a blocked ectopic atrial contraction. In other words, how do you know that This right here is not a blocked P wave. That is an ectopic beat. You think about it, you will find out that it's not punctual, number one. Number two, the configuration will be different. Okay? Practice becomes clear to you as we do more of this. So here is this. Christian, what is it that makes this a first degree heavy block?
It's just prolonged.
What is prolonged?
The interval.
What interval?
PR interval.
Thank you. So this is, we should see an EKG like this. I mean, the axis is fine, right? The rate is about 1, 2, 3, 4, 75, right? Rhythm is pretty regular, right? Orientation, yeah, is down in AVR, is up in 1. Waves, P wave, yeah, they're there. But look at the PR interval. It's over 2 big boxes. You see this is a patient with first degree AV block. This patient is not going to come to you complaining of anything. Okay? You're just going to have to notice this and diagnose it. First degree AV block is completely asymptomatic. Is there anyone in this class that cannot see prolonged PR interval on this EKG? You're all good with this, right? Excellent.
Just a quick question, just
Yes.
to clarify. Which would be the rhythm rate of this key?
This is
Is that
these two.
Okay.
Actually, they gave you 3 rhythm strips here. That is crazy. Give you V1, 2, and V5.
Okay.
Anytime a particular lead is recorded throughout the paper, that is the rhythm strip. Okay. Most of the time, the standard is for you to have 12 EKG and 1 rhythm strip. Okay. But some machine will give you 2 rhythm strips, 1 precordial and 1 liquid. Okay. So usually it's V1 and 2, or V1 or 2. Okay. Excellent. So look at a type 1 second degree AV block. Look at it. You start out here. Normal PR interval, right? The next beat, the PR interval almost double. By the next beat, it's almost 2.5. By the fourth one, it's 3 times, and then the 5th P wave got dropped. Okay, so you say this is definitely a second degree AV block, Wenckebach type, or type 1 second degree AV block, right? Now, it is not enough to say that somebody has second degree AV block, Wenckebach type. You need to be able to describe it. You need to tell me, how serious is it? How serious is it? In other words, a second degree AV block, is it 10 to 1? Is it 1, 5 to 4, whatever it is? Because that tells you the severity of the block. When it is a Wenckebach type of AV block, the way we describe it is x to x minus 1. So for this one, you will say this patient has 1, 2, 3, 4, 5 to 4 Wenckebach second degree AV block. What you're saying is that for every 5 P waves, 4 gets conducted. Why is that important? Because that means here the patient is only dropping every 50 P waves. If it is 3 to 2, that means every 3rd P wave is getting dropped. That severity, that ratio is related to whether or not the patient will be symptomatic. If you have a 6 to 5 Wenckebach or 7 to 8, 8 to 7, sorry, Wenckebach, you'll be fine. But if you have like 3 to 2. That is it. We call it a high grade Wenke back. That means you're blocking every third. You know what that means? Think about it. If you're dropping every third beat, if you're at rest when you need only 60 to 100, you'll be fine, because if you keep dropping every third beat, at 90, your rate will be 60 because you're dropping every third. But say you now decide to go run on the treadmill, and you really need about 120 for you to be able to do the exercise. If you keep dropping every drop beat, your heart rate will never be able to go past 80. You will pass out in the middle of the exercise. So you see, that is why you talk about the ratio to kind of have a sense of the degree of the block. And when the ratio is kind of high, like 3 to 2, you say that is a high grade Wenke back. Okay? I want you to pay attention. The way you describe the severity of Wenke back is x to x minus 1. Okay? X, you count to the one that was dropped, and then you minus 1 because one was that was the one that was dropped. So in this case, it will be 1, 2, 3, 4, 5 to 4. And in this case, 1, 2, 3, 4, 4 to 3. Right? You got it? Right? So you know why this is 5 to 4 and this is 4 to 3, right? Everybody does that. Okay? Excellent.
You said 3 to 2 is when it's considered severe?
3 to 2 is high grade. 3 to 2 is high grade. And if it is more than 3 to 2, 3 to 2 and up is high grade. Okay? Now, so this is Wenke back. This is how it looks. If you step back and just take a casual glance at this EKG, the first thing that strikes you is this P wave did not get conducted. So there's excess P wave. That tells you right there and then that this is a second degree AV block. You now take a closer look and you see, oh, there is PR, progressive prolongation of PR. So you always start with the drop P wave and look back. Oh, this is really long. Oh, shorter, normal. So there is progressive prolongation. So this is what makes it Wenke back. Type 1 second degree AV block. Okay? Look at Mobius. This is Mobius. Once you take a look at this, what strikes you? A lot of P waves without QRS, right? And then you look at it, it's like, wow, this one got conducted. There's a partial P wave there. This one got blocked. This one got blocked. And this one got conducted. Got blocked. Got blocked. Got conducted. You see the pattern is different here, right? There is PR interval is normal. When it is conducted, PR interval is normal. But not all the P's get conducted. That is the nature of Mobius. That is what makes Mobius deadly. You can't afford to miss a Mobius, a type 2 second degree AV block. And the way we describe Mobius is x to 1. Right? So 1, 2 got conducted. So this is 3 to 1. Of every 3, 1 gets conducted. 1, 2, 3 got conducted. So it's 3 to 1. Okay? So you describe the number of P before the one that got conducted. So it's always x to 1. Okay? So here you have 1, 2. This is the third one that got conducted. So this will be 3 to 1. Okay? And here it will be 1, 2, 2 to 1. Right? So how many P waves does it take to get 1 to go through? That is so it is important to learn. So even from the way you describe the severity, somebody can tell if you're talking about a Mobius type or a Wenke back type. Because Mobius is always something to 1. Okay, whereas Wenke back is x to x minus 1. Okay.
Dr. Martins?
Yes.
Which strip is the best to look at when you're looking for
Rhythm strip.
Okay,
Rate and rhythm abnormalities can only and should only be ascertained from the rhythm strip. The only time you should manage to make a rate and rhythm abnormality decision on an EKG is when you don't have a rhythm strip. And if your decision is going to have life-death implication for the patient, you should ask for a rhythm strip. Okay? You should not make rate and rhythm decision based on EKG. You should always use rhythm strip. That is why the rhythm strip is there. Okay? Excellent. Everybody clear with this? Good. There is a problem. When you have, remember, for you to say something is wanky back or movies, you need to be able to see a PR interval, right? At least 2 PR intervals, right? Because for you to say wanky back, you have to see prolongation of the PR interval, right? For you to say this is Mobius, you have to see a normal PR interval, right? So when you have a heart block that is 2-to-1, how do you tell whether it's Mobius or wanky back? Because in order for you to call it wanky back, you need to see at least 2, right? That is what the point I'm trying to make here. Here is a 2-to-1 block, right? Boom, 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 right there. You see, it's a 2-to-1 block because you see that 2, and this one is blocked, this one went through, this one get conducted, this one get blocked. Conducted, 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 blocked, conducted. So it's, under normal circumstances, both of these will 2-to-1, 2-to-1. How do you know whether it's wanky back or Mobius? You really can't tell. But there is one clue on the EKG. Can anybody tell me what that clue might be? When you see a 2-to-1 block, what is it that you can see that will convince you that this is wanky back or Mobius?
The length of the PR interval?
Thank you. If the PR interval is normal, it could be Mobius or wanky back. But if the PR interval, the only one PR interval you can see is abnormal, it can only be wanky back. You got it? Good. Very important. That's the point of this slide. You see, a 3rd-degree AV block is complete dissociation. And this is how it looks. You see the P wave doing their own thing.
Question.
Yes.
So let's say in a scenario that you don't see a extension, but it's normal. You said it could still be wanky back.
Yeah, because remember, wanky back starts with normal, gets prolonged, get longer, and then it dropped. But it could also start with long, longer, longest, and dropped. That is why if it is normal, you can't say it's Mobius or wanky back. Because sometimes wanky back can start with a normal. What characterizes wanky back is progressive prolongation. Whether it starts out normal or it starts a little bit prolonged is immaterial. What matters is that it gets progressively longer. And if the only one you're seeing is long, then you know this is wanky back. Because in Mobius, PR interval is really normal.
So that previous picture, the top one was morbid.
Why did you say that?
Because the PR interval stay was the
Yeah. No, you really can't tell. That's why I put the two together. Because PR interval is it's normal here. Because if you look at here, it's a little bit inside here in this big box, a little bit outside of this big box. So it's the PR interval you can see in this particular strip is really normal, right? And the same thing here. And they're both looking like 2-to-1, right? So you really cannot tell based on this. You can't tell which one is which. I'm saying that if PR interval is normal, in a 2-to-1 block, you can only say this is a 2nd-degree AV block. You can't say it's wanky back or Mobius. But if the PR interval is abnormal, long, then you say, oh, no, this is the 2nd-degree AV block, most likely. when keep back because the PR interval is small. Okay, that's a reasonable assumption you can make. You got it? Okay. Look at third degree heavy block. In third degree heavy block, the P waves are not associated with the QRS. They're doing their own thing. P wave, the P wave are marching right through. As a matter of fact, sometimes the P wave will coincide with the T wave of the ventricle. And you will get these humongous waves that are called summation waves. And the way you know it is take a piece of paper, put your 2 mark on the PP interval, and you will march that paper through, and you will see where the hidden P waves are. Because sometimes the P wave will be hidden within the QRS, or it will add up to the T, and the T will look weird. Right? And then you just march it right through. And then you will now do the same thing for the QRS, even without marching anything. Once you step back and you look at this, you can see the ventricular rate is low, the atrial rate is really fast. Right? Is that not obvious here? Look at it, 2 P waves. Look at the 2 QRS. The atrial rate is faster here than the ventricular rate. So that tells you already they are not working together. They are already going their separate ways. Right? Okay, so I'm switching gear now. Whenever the P wave, the atrial and the ventricular activity are not coordinated, then there will be times when the atria is contracting at the same time as the ventricle. When that happens, what do you think will happen to the A wave in the neck? It shoots up, exactly, and that is what is called Cannon waves. Okay, remember that, right? Okay. So now let's talk about escape beats. So now you're good on heart blocks, right? You know how to tell sinus arrest from SA nodal block. You know when there is AV nodal block, the type 1, the type 2, and the type 3. You know how to tell when Quebec from MOBIs of type 2 based on progressive prolongation of the P waves, right? And remember, make these decisions only on a rhythm strip. Okay, rhythm strip. So let's talk about escape beats. What is an escape beat? Remember I told you that the only reason the SA node is in charge of the rhythm of the heart is because it has the highest intrinsic rate. That is the reason. Whenever the SA node loses dominance, when its intrinsic rate falls below 60, the other pacemakers begin to challenge the SA node. Because the reason that they are not taking over is because the SA node is suppressing them. So when the SA node rate goes below 60, the junctional pacemakers begin to say, hey, we're about the same rate now. Why should you be in charge? So you begin to get this escape bit so that the interval between the normal QRS there will be beats coming from other pacemakers to fill that gap, to show that I can do what you're doing now. So the pacemaker foci below the SA node recover from its overriding suppression and fill in the long pulses with backup beats. Escape beats, they can come from any pacemaker foci below the SA node. They can come from the atrial, they can come from the AV junction, or they can come from the ventricle. Okay? The shape of the PQRS T wave of the escape beat determines its point of origin. So how do you know when this escape beat is coming from the ventricle? The QRS will be crazy. The configuration will be crazy. If it's coming from the junction, depending whether it's a high junction or low junction, it can depolarize the atria in the reverse direction, in which case the P wave that is supposed to be before the QRS will come after the QRS. And not only will it be late, it will be inverted, because atrial depolarization is now proceeding upwards instead of downwards. We'll talk about that. This makes sense to you, right? How SA node can lose its dominance when its rate is below 60, and how the other foci can take over, and they can come from the junction or the ventricle or other atrial foci. I hope you realize that when I said atrial escape beat, I'm not talking about atrial muscle. I'm talking about those internodal tracts in the atrium. That is electrical tissue outside of the SA node. I'm not talking about atrial muscle. Atrial muscle does not have inherent electrical activity. You remember that, right? Yeah. Okay, good. So look at this. This is your sinus rhythm. You see the P get conducted to the AV node, the ventricle depolarizes, you get the QRS, the ventricle repolarizes, you get the T wave, and the cycle repeats. If something happens and a foci in the internodal tract decides to take over because the SA node is losing dominant, see what happens to the P wave configuration. You see how different that P wave looks, right? This P wave and this P wave are not the same. You all agree with me?
Yeah.
Excellent. But you really have to know what you're looking for, right? This P wave is different from this P wave. That means this complex did not come from the SA node. Okay? But if you see the QRS T is exactly the same. Why is that? That is because, yes, the impulse came outside of the SA node, but it still got delivered to the AV node. So the AV nodal conduction and ventricular depolarization proceeded exactly the same way as it would have if it had come from the SA node. So most of the time, when you have an atrial escape beat, the QRST is the same, but the P wave is the one that is off. Okay? And look at a ventricular escape beat. So this is sinus rhythm. Look at the P, QRST, P, QRST, P, QRST. And then see there is a big pause and followed by this crazy complex right here. This crazy complex has a QRS, one that is not preceded by a P wave, right? And does not look like the other. The configuration of it is different from the configuration of the prior QRST. That is how you know this is an escape beat that came from the ventricle. Okay? So, that is a ventricular escape beat. Okay? Okay. You all with me on that? Now let's combine it now. Let's combine this conversation. We've talked about SA nodal block, right? We talked about sinus arrest. We talked about them creating lung pulses, right? And these escape beats will begin to challenge the SA node because it's taking longer now to pace the heart. So look at this strip right here. You have PQRS T, PQRST, with prolonged QT by the way. PQRS, crazy artifact right there. And then PQRS, then you get this. Look at this. This complex right here. Can you see the difference between this complex and this complex? What are some of the major differences, Ali, between this complex and this complex? What is it that you can see here that is like, something is not right?
It's not a well-defined P wave.
It doesn't have a P wave, right? And what else? The QRS itself looks weird, right? But believe me, this right here is actually a P wave. See this right here? It's a P wave. That behavior, that pattern is very common with junctional escape beat. Because remember that the SA node depolarizes the atria and comes down like that, right? That is what is normal. That is why the P wave is upright in most of the leaves. And it could be negative in V1, right? But by and large, it's upright. When you have a reading now coming from, because the SA node is not working properly, you now have a reading coming from the junction. Atrial depolarization proceeds like this, right? And the ventricular depolarization comes down like this. Okay? Now, this is AV node, right? There is bundle of keys, there is right bundle, there is left bundle. All of these are called the junction. If the impulse, the escape beat, comes off of the AV node, it will depolarize the atria and the ventricle at the same time. Right? It will depolarize this and it will depolarize that. And usually you will not see the P wave. Because the P wave will be buried within the QRS. Okay? That makes sense to you, right? If the escape beat is coming from the AV node, it will go up in the opposite direction to depolarize the atria. It will go down in the normal direction to depolarize the ventricles. And because it's going to happen at the same time, the P wave of atrial depolarization will not be visible because it will be buried within the QRS. So you will not see a P wave. That is what happened here. This is a junctional escape beat, right? You don't see any P wave there, right? But, listen, supposing it came from a lower junction, it's still in the junction, but a little bit lower, closer to the ventricle. When that is the case, the repolarization for the atria goes this way still, and it comes down to the ventricle, but this time, the atria will be depolarized a little bit later than the ventricle. So you will get a QRS, and then the P wave will come after the QRS complex. And that was what happened here. So even though this came from the junction, this came from the junction, they did not come from the same place in the junction. This is coming from a lower junction, this is coming from a higher junction. You will see this in EKG reading all the time when people are in junctional reading. When one junction is in charge, you will see this junctional escape beat, and you might see the retrograde wave, the inverted P wave, that is telling you the atria is getting depolarized, but it's getting depolarized in the opposite direction, not the way it should be. So the P wave, not only will the P wave now come after the QRS, it will actually be inverted. Okay? And if it happens right at the junction in opposite direction at the same time, the P wave will be completely dropped. It will be buried within the QRS. Okay? Are you with me? Good. So you understand why this is a junctional escape bit. This is also a junctional escape bit, but it didn't come from the same place.
Which one would be higher and which one would be lower?
Tell me, which one? Which one do you think is higher, which one is lower?
I think
The right or the left?
the one that's buried, I'm assuming is higher.
Yes, exactly. If it's higher, it will depolarize the ventricle at the same time as the atrium. So the P wave will not be independent. It will be buried within the QRS. You won't see it. But if it is lower, because when it is lower down in the junction, it's closer to the ventricle, the QRS will take place, but then the P wave will appear much later after the QRS because the impulse now has to travel up the junction. So the atrial depolarization will not happen at exactly the same time. It will follow the QRS immediately, and it will be an inverted P right after it. Okay? So here you see something. This is V1, as you can see, because he has that biphasic P wave, right? So this is a P wave conducted, P wave conducted, P wave conducted, P wave conducted. And then see what happens. A P wave came, then it got dropped. It didn't get conducted. And before the SA node could recover, two junctional bits fill in that gap. It would be wrong for you to measure this as the RR interval, because this complex and this complex are not the same. This complex does not have a P wave to it. This does not have a P wave to it. These are junctional bits. This is a drop P wave, creating this long pause, and the junction, the bits, this junctional escape rhythm filled it. So escape rhythm are usually ectopic bits. The reason we call them ectopic is because they always come from the abnormal origin. That's what makes them ectopic. Ectopic pregnancy, when the pregnancy is not within the womb. Ectopic bits, when the bit did not come from the SA node, it's an ectopic bit. Okay, so an ectopic bit can come from the atrial, in which case it's an atrial ectopic. It can come from the junction, in which case it's a junctional ectopic, and it can come from the ventricle, in which case it's a ventricular ectopic. But remember, I did not call them ectopic, I call them escape. Escape bits are usually ectopic bits, but not all ectopic bits are escape bits. Remember I talked about the premature atrial contraction? Because escape bits usually come later than the expected bits, so they represent escape, whereas premature comes before the normal beat. Okay, so let me give you a good example. Say you have a strip like this. See, this is a normal beat, this is a normal beat, this is a normal beat. The next normal beat is supposed to be somewhere around here, right? But it came sooner. You will call this bit a premature bit. It's an ectopic bit, right? But it's a premature bit. If supposing, instead of coming here, it came right here. Because it's coming after the expected duration, it's an escape bit. It's still ectopic. What makes it ectopic is its origin. Whether it's an escape or premature is its timing. Okay, so I don't want you to get confused because some people use those two terms indiscriminately. Escape bits and premature bits is a description of the timing of ectopic bits. They are both ectopics. What differentiates them is in their timing. One comes earlier than expected, the other comes later than expected. Premature bits come earlier, escape come later. Okay? Okay, so let's delve into this. So, that is an interesting jump. So when the SA node loses its ability to set the pace of the heart, Other foci in the atria begin to challenge it. Most of the time they are from the internodal tracts, anterior, posterior, internodal tracts, and all that. And they will start competing with themselves for who is going to take over. And for a minute, all of them will be trying to pace the heart at the same time. So you have 3 ectopic sites trying to see who is going to dominate. But they are all below the atria and above the ventricle, so they are really close. None of them is going to win because they are inherently the same. They're coming from the same place. Okay? You know, the Kenyans always win the marathon whenever they come out. And the only way you can actually defeat them is to defeat one particular Kenyan, is to get another Kenyan to come and compete with him and keep up. Nobody else will do it. Because they all are from the same environment and they have the same physiology that enhances their ability to do that. The same way, when the SA node loses dominance and the atrial foci now begin to compete to dominate, they don't often succeed. So what they end up doing is just messing up the rhythm of the heart. This one will come, this one will come, that one will come, this one will come, that one will come. They're all doing it. None of them eventually dominates. How does that look on the EKG? The way you see that on the EKG is that the QRS will always be the same because they're coming from above the AV node. So QRS will be fine. But the P wave would always be different. Anytime you see more than 2 different P waves on a rhythm script, but the QRS is the same. But the P waves are different, and each P wave seems to be coming at a particular interval. So it could be 3 points in the atria. We'll call them A, B, C. So A fires, B fires, C fires. The P wave from A is different from the P wave that B will generate, from the P wave that C will generate. So there will be at least 3 types of P waves, right? And you can recognize A because every 4th P wave will be an A configuration. Every 4th B wave might be a B configuration. Depending on where they are, they maintain that configuration. So when you look at the EKG, you see the rate is usually normal. The QRS complexes are fine, but the P wave configuration is, you can recognize at least 3 different P wave configurations. Whenever that happens, we say the patient has a wandering pacemaker. Okay? A wandering pacemaker. That means the tissue that is in charge of the heart is wandering from one atria to another. It's not because that pacemaker is actually moving around. No, it just means that the dominance of the pacemaking activity of the heart is shifting from one focus to another focus. Okay? That is what we call a wandering pacemaker. Now, 3 characteristics of wandering pacemaker that you must know is that the P waves are different. Look at this P wave. QRS is fine, but look at this P wave. See how tall and big it is. Look at this P wave. Not only is it inverted, right? But it's quite different from this. Look at this P wave and this P wave are very close, right? Right? But this P wave and this P wave are not the same. So you're looking at a rhythm strip and you're looking at P waves, and the P waves are of different configuration, and you can recognize at least 3 different configurations. Immediately you begin to think this is probably a wandering pacemaker. Now, In order for you to truly call it a wandering pacemaker, the rate has to be less than 100. Okay? And the rhythm is irregular. Okay? Remember, it's got to be irregular if 3 sides are taking over the pacemaking of the heart. It can't be regular. The only way it can be regular is if one side is doing it. If 3 sides are doing it, it can't be regular, right? So in order for it to qualify as a wandering pacemaker, it has to have P wave of different configuration, and you can recognize at least 3 of them. The rate has to be normal between 60 to 100, and the ventricular response is irregular. Remember I told you earlier that we always use the rate information to validate the rhythm information, and we use the rhythm information to validate the rate information. This is one place where that information, what I just told you, is important. Because you know what? If you see exactly the same pattern, multiple P waves, but the rate is tachycardic, you don't call it wandering pacemaker. You call it MFAT. Multifocal atrial tachycardia.
What is your multi?
Multifocal atrial tachycardia is an irregular rhythm with multiple P wave configuration. Rate is tachycardic. Is between 100 and 150 usually. Okay? You see what I mean by rate and rhythm are 2 different things. If the rate is normal, it's a wandering pacemaker. If the rate is high, it's multifocal atrial tachycardia. And that is very common in COPD patients. Okay? Good. Y'all with me so far, right? Everybody's good?
Did you say was COPD? Was it wandering or was it?
No, NFAT. NFAT is common in COPD patients. Yeah. Okay? Now, an escape beat is a single beat. But if that single beat escapes and was able to dominate and establish its own rhythm as the rhythm of the heart, you now say the patient has gone from an escape beat to an escape rhythm. For instance, see what happened here. This is SA node, SA node, SA node, right? Then there was a pause. Then this beat came. This beat here is an escape beat, right? Why is it, or is it a premature beat? Vinny, is it a premature or escape beat? It's an escape beat. Why is it an escape beat?
You expected earlier.
Exactly, it came later than expected because it should have come 1, 2, 3, 4, half 1, 2, 3. It should have come right about here. That was where the beat should have come, but it came here. So it's an escape beat, right? Where do you think this beat came from? Did it come from the ventricle or from the junction? Eh? Junction, exactly. Why do you say junction?
Slower.
Because it's narrow, right? It's narrow and it's lower, right? It's narrow. If it had come from the ventricles, it would be bizarre. Okay? But the QRS duration is normal. That means it's coming from high junction, really. Because you see, it doesn't have the P wave, right? Does it have a P wave?
No.
It doesn't have a P wave. If it doesn't have a P wave, that means it's a high junction radio. It came from the junction and is high in the junction. All right? And then see what happens? It sets itself as the rhythm now. So this escape beat has become escape rhythm because going forward, this was what we now saw. So whenever an escape beat establishes itself, establishes its own rhythm as the normal rhythm of the heart, and you never see the SA nodal rhythm anymore, you say the patient has gone into a junctional rhythm. So we say you're doing rotation. I am hoping that we can get you guys to rotate through some coronary care unit or even telemetry where you monitor patients, and you can see some of these things because it's interesting to see. In telemetry unit, they have nurses sitting at the station doing nothing but their eyes glued on the on the rhythm strip, right? And patients can go from occasional junctional escape beats, and I say a patient is gone into junctional rhythm. That means that escape beat, that ectopic foci has now taken over, and the patient has now gone from escape beat to escape rhythm. Okay? So basically, escape rhythm is when the escape beat now becomes the dominant rhythm. Okay? Yeah.
Where you go on to the junction, where it's enough to know lower junction.
No, it couldn't come. This right here couldn't come from the lower junction, because if it came from lower junction, usually you will see a P wave after it that will be inverted. Remember that diagram I drew there? Yeah. If the reason you can't see a P wave here is because it's buried within it, and that's really what you see in the high junctional rhythm. Okay, you got it? Excellent. So here you go. So Tolu, take a look at this rhythm. What is this rhythm here? Is this a sinus rhythm? Is this a sinus rhythm? Okay. Even though these two rhythms are the same thing, I want you to make your decision based on the rhythm over here. So you see that this is your one rhythm, this is another rhythm. Where do you think this rhythm is coming from? It's coming from the ventricle. How did you know that?
Because of the way the,
Because the QRS is weird and is wide, right? So it's coming from the ventricle, right? Good. What are these? It's pretty consistent. What are those? Okay, they are P waves. They are coming after the QRS. They are P waves, but they are upright. So the fact that they are upright means they are not getting retrogradely conducted. And moreover, it is impossible. Impulses don't travel from the ventricle upward to diagnose. Only at the junction can they do that. Once it's coming from the ventricle, it cannot retrogradely activate the atria. It doesn't happen. So you're right, this is a ventricular rhythm. But why do you think you have the P waves like this? No, ectopic, consistently like that. That is the feature of AV dissociation. The atria is doing its own thing, the ventricle is doing its own thing. They are dissociated, so the ventricle is conducting at its own rate, the atria are coming on at their own rate. So this P wave here is a sign of AV dissociation. Okay? From here, something happened. This site took over. If you match a paper through this, you will see that this rate here is consistent. It's buried here. It comes here, comes here. You see that the atrial impulses are regular. The ventricular impulses are separate. Now, this you said is coming from the ventricles, and you're right. And the reason it's coming from the ventricle is because it looks like a PVC, but it's the one ruling the heart. So it is right. It's a rhythm that is coming from the ventricle and is dominating. What is the expected inherent rate for a ventricular foci? less than 40, right? But what is the rate here? It's about 70. 100?
Less than 100.
A little less than 100, right? But maybe 80 there about. 1, 2, 3. 300 divided by 8 is by a little less than 100, right? Is that what you, if it is coming from the ventricle, why is it 100? Because ventricle, under normal circumstances, the ventricles are not supposed to be able to generate. Their basic inherent rate is about 20 to 40, right? So when you have a rhythm that you know is coming from the ventricle, but is off in rate, that is what you call an accelerated idioventricular rhythm. In other words, it's a ventricular rhythm, but it's accelerated because it is above the rate that you expect it to be. You see, when I told you that you always use rate information to validate your rhythm impression, and you use rhythm information to validate your rate impression. If I show you exactly the same rhythm strip, and I make the rate 38, you will call it idioventricular rhythm, period. But because the rate is above what you expect from the ventricle, you will call it accelerated idioventricular rhythm. It's just the same way, the same principles. You call it wandering pacemaker because the rate is normal, less than 100. You call it multifocal atrial tachycardia because the rate is above 100. Yet, the same strip. The difference is the same strip with multiple P-wave configuration, irregular ventricular response, and at least 3 different types of P-waves. If the rate is more than 100, you call it multifocal atrial tachycardia. You take the same strip and the rate is now less than 100, you call it wandering pacemaker. You take the same wide QRS complex, on a rhythm strip. The rate is less than 40. You say, well, this is a ventricular rhythm. We call it idioventricular rhythm. But you take exactly the same rhythm and the rate is now 60. You say, well, the rhythm is ventricular, but that rate is too high for a ventricular rhythm. You now call it accelerated idioventricular rhythm. Yeah. Okay?
How is that possible?
How is that possible? You know, we don't know everything, but we know that there are protective mechanisms in the heart. Number one, the ventricles are disconnected from the autonomic nervous system. But they have some kind of connection that allows them to, when they step up and they know they are it, they step up their rate to keep the patient going. It's a survival mechanism. We don't know why or how it happens. Okay? Some say it has to do with the mechanoreceptors in the ventricles. Depending on how the ventricles get stretched, it can decide whether the patient is bleeding or not bleeding, and that stretch can determine the rate at which, not only the rate at which it recoils, but even the rate at which the electrical activity goes on. It's a protective mechanism. It really is a protective mechanism. Okay. The ventricles, you find out when we come to syncope, they have, in the heart and the brain, there are so many protective mechanisms that we don't understand. Organs behave the way they shouldn't behave, but that abnormal behavior is responsible for the reason patients survive. Okay, accelerated idioventricular rhythm is so important. If somebody gets a massive MI that takes out the AV node, many times they will arrive in the hospital in accelerated idioventricular rhythm because the ventricle is able to do this. We don't know why or how it does it. Okay.
And then how long can they survive? Because
They will survive. This rhythm is a stable rhythm.
This is their set rhythm.
It's a stable rhythm, yes.
Okay.
The only time it will change is if you now give them thrombolytics and you restore blood flow, and the AV node recovers and comes on with its own inherent rate. will now kick it over. And the SA node recovers, it takes it over. So this is a survival rhythm. Okay, it's a stable rhythm. Yes, Kiara?
So you said when you have ventricular impulses, it doesn't go back up to depolarize the atrium?
No, you don't get, impulses don't go from the ventricle up the branches to the onto the atrium. No.
So then what's responsible for atrial contraction? We have a P wave here, right? So what's causing that atrial contraction?
Yes, sir.
So the SA node is still working, but now we also have a ventricular?
Yes. Because, you know what I said, that rhythm is always in atrioventricular dissociation.
Oh, okay.
In AV dissociation, the SA node is working and the ventricular fibers are working, but they're not communicating. The AV node and the entire junction is out. You get that when you have a serious septal impact, anterior myocardial infarction, that takes out the septum and the conducting tissue, takes out the entire junction, such that the SA node is disconnected from the ventricles and they're now doing their own thing. That is why the P wave are upright. Tell you that the SA node is still okay. Right? Good question. You had a question?
Can you go over the first rhythm trip again, Dr. Martin?
The one on top?
Right.
No, the one on top is the same rhythm, is the same patient at the same time. I just put it there to let you know that sometimes you have to look, if you have more than one rhythm strip and one does not make a lot of sense, look for the one, look at all the rhythm strips, because you see the first one and the second one, they are the same patient recorded at the same time, but the story is clearer in the second one than in the first one. That's why I'm not talking about it. I put it there to show you to you that, well, when rhythm strips don't make sense, look for a lead that makes sense. If the limb lead does not make sense, look for a chest lead. Most of the time, the rhythm strip will come from lead 2 or V1. Okay. So I don't want, it's nothing to go over other than to tell you that actually this P wave that you're seeing here is shown here, but it's not consistent in this particular one. Whereas here it is consistent, you can see it. That's how you know that this ventricle is not communicating with its own atrium. Okay? All right. You're good with that, right? Escape beat, escape rhythm. Now you know about multifocal atrial tachycardia, you know about wandering pacemaker, you know about idioventricular rhythm, you know about accelerated idioventricular rhythm. It looks like a lot of stuff is not. Think about it. The same strip that you call wandering pacemaker is exactly what you call multifocal atrial tachycardia. The only difference is the rate. The same strip that you call idioventricular rhythm is what you call accelerated idioventricular rhythm. The only difference is the rate. Okay? Now, what is six sinus syndrome? Six sinus syndrome is an SA node dysfunction. It is usually associated with heart valve and ischemic heart disease. Why is it called six sinus? Because the SA node is really sick. It is characterized by alternating slow and fast abnormal rhythm with long pauses of sinus block and arrest. So, in a six sinus syndrome, patient has both sinus arrest and sinus block. But what makes it weird is that if it was just sinus arrest and sinus block, you always get bradycardia, right? But these patients will present with fast and slow rhythm. So how do you know a patient that has six sinus syndrome? They're usually elderly, most of the time in their 70s. They have risk factors, sarcoidosis, hypertension, diabetes, lupus, whatever it is. Some scarring condition that is involving the heart. And how do they present to you in the same visit with fast and slow rhythm? No. The patient will be hospitalized maybe 3 weeks before they see you. And ER will say they came in there with sinus tachycardia. Okay, sinus tachycardia. And they have no reason for it, but just sinus tachycardia. And the heart rate went so high that they developed chest pain. They end up in the emergency room. And then you're looking at them in the clinic, and their heart rate is 48. And you say, wait a minute. The emergency room doctor gave you atenolol because you were there for heart rate. But now, your heart rate is 48. You say, okay, no, stop the atenolol. You stop the atenolol. You say, come back and see me in 2 weeks. Patient comes back 2 weeks off of atenolol, and the rate is still 48. And like, well, I'm just going to discontinue the atenolol. And then you get a call the next day to the emergency room for tachycardia. Are you following the story? So this is a crazy patient. Not the patient is not crazy, but the presentation is crazy. When you look at the history, not that encounter, but the patient's history, they have episodes of bradycardia, episodes of tachycardia. That is why sick sinus syndrome is also known as brady-tachy syndrome. Okay? Or tachy-brady syndrome. It does not matter. What is important is that they have episodes of alternating slow and fast rhythm. This is the same patient. Look at the rhythm here. See how brady it is? Unfortunately, this patient went in with this rhythm, but while on admission, developed this rhythm. And then went on for a while and then went back to the slow rhythm. This is not the usual case. This is an example that they were lucky to record this, because usually it is not in the same encounter that your patient presents with tachybrady. So remember, I hope you realize that this is one strip. Right? Patient was brady here, became tachy here, and went back to brady. So this is a sick sinus syndrome when this SA node is really sick. And what it does is, let me tell you why I believe this is happening. I believe the patient really has a sick SA node. I think the patient really, the primary disorder is an SA block, a sinus arrest. It's so severe that when the patient is brady, the autonomic nervous system gets wild up. And then when the block relieves, all of that autonomic impulse now drives the SA node to compensate for the brady episode. And then the patient goes into that tachy rhythm under the influence of the autonomic impulse. And then once that hormonal adrenaline or catecholamine is subsided, the patient goes back into their baseline rhythm until the cycle repeats itself. That, I believe, is what is really driving this. Because invariably, what do we do for this patient? We give them pacemakers. Okay. All right. So we've talked about rhythm. I just want to let you know what we've talked about. If the rate is regular, if the rhythm is regular, you use the rate to figure out what is going on. If the rhythm is regular and the rate is less than 60, it's either sinus bradycardia or an escape rhythm. It could be AV or it could be idioventricular. Okay? So this is just a summary slide. If the rate is between 60 and 100, which is normal, that is either normal sinus rhythm, but remember, it could be an accelerated escape rhythm, which will come from atrial, junctional, or from the ventricle. If it is irregular and it's less than 60, it's a heart block. It could be SA node or second degree AV block. If it is 60 to 100 and it's irregular, it's a wandering pacemaker. Okay? So this is just a summary of everything we talked about this morning. All right. So I think I do have some test things for us. Maureen, so tell me, here is a 48-year-old female hypertensive on Tenoritic. Tenoritic is a combination pill of atenolol and hydrochlorothiazide. Okay, so together it's called Tenoritic. And this is your rhythm strip. What do you see here? Is it sinus bradycardia with ventricular escape beat? Is it junctional rhythm with a ventricular escape beat? Is it sinus bradycardia with the jet lag? What is going on here? Okay, let's walk through it. Let's walk through it together. What do you think about this particular complex? It looks like an SA node type of a bit, right? It has P, QRS, T wave over there. What do you think about this one?
It doesn't have the P.
Okay, it does not have the P. What else is wrong with it?
It's in the bar count.
It is wide, right? Okay. Exactly, and the P wave seems like it's embedded in it. But wait a minute now. Is it? It is wide, right? Okay. Is it the same thing as this one?
Yeah.
Is it the same thing as this one? Okay, so this complex and this complex came from the same place, right? This is your background rhythm. So this right here is the abnormal rhythm. You said it doesn't have a P wave, right? And the QRS is wide. So where is it coming from? Is it coming from the junction or is it coming from the ventricle? Thank you. It's coming from the ventricle. It's coming from the ventricle because it's wide. Now, so we know it's a ventricular beat, right? So, what is the answer? Is it sinus bradycardia with a ventricular escape beat? Or is it a junctional rhythm with a ventricular escape beat? Maureen,
Yes.
so what is it?
Junctional rhythm.
It's a junctional.
No sinus.
Sinus rhythm.
Thank you. It's a sinus bradycardia with ventricular escape beats. Okay, so this is because when you look at the whole strip, there are 1, 2, 3, 4, 5, 6. There are 6 complexes. 4 of them are similar, they're close. That is your dominant rhythm, right? And because it has this PQRST, PQRS, you can tell, okay, this looks like this is the SA node. The intruders here are these ones. It does not have a P wave. So because it doesn't have a P wave, there are only 2 places it could come from, junction or the ventricle, right? If it's coming from the junction, it will not have a P wave, but it will be narrow, right? If it's coming from the ventricle, it will not have a P wave, but it will be wide. And because it is wide, because it has 1, 2, 3, 4, it's more than 3 small boxes. So this is what makes it sinus bradycardia with ventricular escape beats. And as a matter of fact, technically speaking, I can say sinus bradycardia with premature ventricular contraction. Okay? Because it's premature. It came sooner than expected, right? But because the reason I cannot call it premature is because the background rate is already slow. So you can't really call it premature because the background rate is abnormal. There is a background bradycardia. You understand what I'm saying? If the background rate was normal and it came earlier, you would call it premature. But because the background rate is already slow, it's an escape rhythm. Okay? And what makes it ventricular escape is because the QRS is wide. It came from the ventricle. Are you all clear on why that is the right answer? Anybody has any question? Yes.
So what if it is a junctional rhythm?
If it was a junctional rhythm, the QRS would be narrow. The QRS duration would be normal. So it won't be this wide. If you look here, it's more than 3 small boxes. Junctional, remember, junctional means that it's coming either from the AV node, bundle of keys, or bundle branches. So the ventricular depolarization proceeds normally. So the QRS duration is usually normal. Okay? Yes, Brad.
Does the same rule apply if you had so you said because the background rate is slow, you can't have the PVC.
You can't call it premature because the background, premature means that it's coming earlier than expected. But that is assuming that the expectation is normal rate.
Right, so does the same rule apply for PAC if the?
Simply, yes, exactly, yeah. Okay, yes.
So the first half is describing like the background rate, and then the second half is describing our abdomen, right? So like sinus bradycardia is like our. Like,
Exactly.
background rate.
Sinus bradycardia is your dominant rate. Is due to, that's why tenoretic would do that. It's a beta blocker, right? Atenolol is a beta blocker. So atenolol is causing the sinus bradycardia. And because of the persistent bradycardia, this ventricular ectopic foci is filling in the gap, right? Y'all good with this? Excellent. David,
Yes.
so here is a 65-year-old male smoker on admission for myocardial infarction. What's going on here?
So it looks like it missed a beat. And
Good.
the-
So you have excess P wave, right? That's what you mean by
Yes.
missed. So it's definitely a second degree heart block, right?
Mhm.
So what type it is? Is it?
I would say Mobitz because
Exactly.
the PRs aren't.
Everybody agrees?
Yeah.
This is a Mobius 2-to-1 second degree AP block, right? Because see, normal conduction PQRST, normal conduction PQRST, regular rate, normal conduction PDRST, boom, this P wave got blocked. The PR interval is constant all through, right? So it's a second degree heart block because the P wave did not get conducted. It is Mobius because the preceding PR intervals were normal. And after that, it get conducted again, and that conduction is very similar to this. So the answer here is 2-to-1. Mobius. Okay? It's not third degree AV dissociation, no, because each P wave is associated with the QRS with the normal PR interval. Yes, proceed. Huh?
You should have 2-to-1.
This is your blocked P wave, right? This is your conducted one. So you can either count forward and 1, 2, blocked, conducted, or you count from, don't count from there because you have several ones that are conducted. You start from the blocked one, right? Now, somebody will ask, why is it not 4-to-3 Wenke back?
Because there's no.
Thank you. You will not use Wenke back to describe this because already the P wave is PR interval is constant. So it's Mobius. If you understand the nomenclature of second degree heart block, once you identify this to be Mobius, you can only call this 2-to-1. If you mistake this for Wenke back, you will call it 1, 2, 3, 4-to-3 Wenke back, but then you'll be dead wrong because PR interval is constant here. Right? Good. Remember what I told you. Use rate information to validate rhythm impression and use rhythm information to validate rate impression. Extremely important. Everybody clear with this? Annette. So here is a 90-year-old female with no significant past medical history. 90-year-old female, no significant past medical history. What is here? Please just tell me. Let's look at this rhythm. What do you think? What is weird here? What is the weirdest thing? Look at this complex. He has a PQRS, right? T. This one too has a PQRS T. What is the difference between this and this? Thank you. The P wave is different here. And then you come over here, well, this P wave looks very similar to this one, right? So they came from the same place. And then look at this one. This one looks neither like this one nor this one. So we are seeing right here at least 3 different P wave configurations. So it could be either wandering pacemaker or multifocal atrial tachycardia. How would you make the dissemination, Annette?
Wandering would be great.
Thank you. So what is the rate here?
Normal.
It's normal. Therefore, this patient doesn't have a disease. She has a wandering pacemaker. Are you all with me?
Mhm.
Excellent. Anybody not clear on this? This is beautiful.
Yeah,
If you understand, yeah.
Can you explain that?
Okay, so this is a rhythm strip. 90-year-old female, she doesn't have any symptom. You look at the rhythm and you see this complex. Everyone seems to have a PQRS, right? But the P wave here is not the same as P wave here.
Yeah.
So that means the P wave came from one spot, maybe SA node, but this one didn't come from the SA node. It came from somewhere else, instead of the SA node. They all got conducted normally, so the QRS is fine. This tells us that there is a second site that is competing.
Oh,
This one came from the same place as this. This is another SA node bit. We know that, right? Because it's so similar. It may not be SA node, but they came from the same place. But this one here does not look like either this one or this one. So that gives us a third atrial site that is depolarizing the ventricle. Whenever you have that, you will have an irregular background rhythm. You have at least 3 different forms of P wave, and the rate is within normal. That is what you call wandering pacemaker. If the rate had been tachycardic, it would have been multifocal atrial tachycardia. Y'all good?
yeah.
Excellent. Any questions, Christian? Okay. All right, Christian, what is this one? This is a 55-year-old female smoker with a history of hypertension and diabetes.
Second degree.
Excellent. You see, I didn't bother to ask you Wenke back or movies. So, and the answer is second degree AB block. What type it is? Is it the Wenke back? Exactly. Good, good. Excellent. Everybody is with me here?
Yeah.
We have no man left behind. Okay. Wendy, what is this?
So that would be 3 to 2.
It will be what? 1, 2, 3, 4. It will be 4 to 3. This is Wenke back. It's always x to x minus 1.
So where do you start counting the impulses from that?
The one, you count the number of, usually the way they will pick it, I will give you this in an exam, and the way they will give you this in an exam is to give you the blocked one and series of complexes before. And generally speaking, you count backwards until you get to that normal PR interval. That was where it started. Okay. So once you get to that one with the normal PR interval, that becomes your 1. Okay. So it'll be 1, 2, 3, 4. 4 got there, but only 3 got conducted. So it's 4 to 3. Okay. Y'all with me?
Mm-hmm.
All right, Wendy. So here is a 65-year-old male hypertensive diabetic with chest pain. What is this? First of all, that rhythm, what is it? Is it, tell me where it's coming from. Is it coming from the atria or is it coming from the ventricle? Thank you. Why did you say it's coming from the ventricle, Wendy? The bottom part? That is not how you make that decision. You make the decision based on the width of the QRS. It is the width of the QRS that tells you whether it's coming from the atrium or the ventricle. If the QRS duration is normal, that is a junctional rhythm. If it does not have P wave. So this could be junctional or ventricular rhythm. But the difference is
Let's do.
the QRS duration is normal in junctional rhythm. It is wide in ventricular rhythm. So you look at this, this is definitely more than 3, right? So it's wide. So because it's wide, it's coming from the ventricle. Now, is it an idioventricular rhythm or an accelerated idioventricular rhythm? How would you make that determination? The rate. So what is the rate here? Let's look for 2 that are on the line. 1, 2, 3, 4. So what is the rate? About 75, right? So what would you call it? Accelerated idioventricular rhythm. Right. It's not, please, never you call this sinus tachycardia because it's not sinus, there is no P wave. It's not sinus because there is no P wave. And moreover, it's not tachycardia. The rate is 75. Is that tachycardia? is not multifocal. You can't even see one P wave there. In order for it to be multifocal, you have to see P waves of different configurations. Right? Since you're not seeing P waves, you can't say it's multifocal. Right? Excellent. Stephanie, so what the heck is going on here? Is a 45-year-old male hypertensive diabetic on admission for chest pain. What do you think this is?
Coming from the ventricle.
You think so? Why did you say that? Do you think the QRS is wide?
Yeah, that's like.
Everybody agree QRS is wide here? Please don't go by what it looks like. Count the boxes. The QRS duration is from here to here. Is that 3 boxes? Exactly. That QRS, it looks wide on a casual glance. But when you count, that QRS is normal. Okay? So it is not a ventricular nothing. All right? So this is why it's sometimes good to have 2 rhythm strips. Because when you look over here, it's difficult to tell what the QRS duration is. Because something keeps cutting off the downward swing of the QRS, right? And when you see multiple P wave like that, so fast that it's cutting off the downward swing of the QRS, what do you think that is? Atrial flutter. I know we've not done it. We're going there. I think I use this to kind of introduce that. Okay? So pay attention to that. Okay? Actually, the point of this slide is to tell you that just because it looks wide to you does not make it wide. The definition of a wide QRS is not your impression. The definition of a wide QRS is the number of small squares. If it's more than 3 small squares, then you call it wide. If it is less than 3 small squares, it's normal. Okay? Yeah.
Is there like a website or something that you use to get these of your practice? Like
Or once there's tons of rhythm strips on Google.
I just want to know if there's a practice problem.
Yeah.
Say it again.
I just want to know if there's like a site with practice problems that you would recommend.
Honestly, I don't have a site, but I know there are sites. And the reason I don't have a site is because it looks complicated to you and stuff like that. By the time you finish the class, you will be masters of this. It's not as complicated as it looks. It's because you're learning for the first time. There will be so much practice. I do cardiology review that has tons of rhythm strips and stuff like that. And once you go, it's mostly, there are sites on the internet. I can look for them for you if you want. Yeah. But I don't have any specific one. The reason I don't recommend those sites is because, especially the ones that are run by, the predominant ones are run by nurses, and sometimes they misread the scripts. And because I've seen where they misread scripts, I'm not comfortable recommending any one site, you know. But in your past practice questions, rhythm strips could come up there. All right, so this is atrial flutter. So let's talk about the other side of, this is just my transition slide. All I've been talking about now is abnormal rhythm. I'm going to go now to talk about increased rate. You want a break?
Yeah.
All right, 5 minutes.
Yeah. Close it out.
Oh, thank you.
Dr. Singh, what is it multiple?
When the P waves are different on a rhythm script, and you can identify at least 3 different P waves. That is what makes it multifocal. Now, if it is multifocal, and and the ventricular response rate is tachycardia, then you call it multifocal atrial tachycardia. But if it is multifocal, but the ventricular response rate is still normal, you call it wandering pacemaker. Got it?
What's going on in here? Thank you, Brad.
No problem.
Can you explain what the difference between why this P-wave
Oh, yeah.
But he made it so you can just stop doing that particular one for
why this P-wave was upright and the other one was connected?
Because in this case, there is AV dissociation.
Okay, this case is AV.
There is using the ventricles to over here because they are not getting any impulse from the atrium. Right? So the atrial is doing its own thing. The ventricles are doing their own thing. So the P waves are coming after the
Right. And then the other one.
The other one is because there is junctional
Junctional, okay.
and there is retrograde
Okay.
depolarization of the atrium. So because of that, backward atrial fluid is
Okay. I just wanted to make sure I didn't write it down. Okay, thank you.
Your other one? Yeah, I did ready. She said she'd be ready. Yeah, good. I did too. I bought all my eggs and I already killed all. It's that. I leave them.
What did I do? Oh, this week you coming up? I'm trying to catch up with everything. You? Yeah, what? Is that the thing you're telling me?
Yes.
Let's do it. Let's do a. We did Nicaragua, and then we're gonna do a Chinese thing. Let's do it. And then we'll do Peruvian for senior. I love Peruvian. We even missed out. That's right. I'm sorry. Missed out too, Cal.
I was sleeping in the car.
You were sleeping in the car?
Yeah, I was going to Santa Barbara. On the way there. For Santa Barbara. That was good? Yeah? Take me.
When did you be there? Because I knew you
Not yet. One day.
Yeah, it's like by downtown. It's like where you just do like no, nobody has that.
Is that your first time?
No. My brother was there, which is just funny.
Oh my god.
I was sitting and like somebody touched my shoulder. I look a lot like that.
I thought you were shaving this weekend.
I got lazy. Because I was supposed to get a haircut. I didn't want to shave it and not get a haircut. I was like, when I get a haircut, I'll shave it all together.
She'll tell us tomorrow, right?
Do you know if Greta is in the provost office? Because she called me 20 minutes ago and I was in class. I didn't pick up. I called her, she didn't pick up.
Where'd you go? In LA?
Okay.
Oh, you were there.
It's part of it. You just gotta get used to it. It's just like people are first day like no rhythm. I don't know. It's because you grew up with this like a child. You're cursing that too? Honestly, like, it's just like it's like your little. It's just like that's honest. Yeah, what people don't do that. You guys like see it's a funny stereotypical sports, but it's a joke. Like, it's kind of so you can really people part of it.
Last year.
Because like when it's parties, like people hanging out, drinking, like talking. That's a funeral for us. For us, a party's like everybody's like, you know, so it's funny. What? It is true, bro. That's why I love you.
What's on next week? Yeah.
How you feeling, bro? Hey, did you guys eat any more of that?
No, dude, I didn't eat that whole thing.
Bro, I was so fueled, bro. Like, I was stuffed, bro. Yuca, bro. I didn't go buy yuca and cook yuca. I was feeling Yeah. Your meal was about everything. What I ate, I didn't take a sip. I know you did. Just like have fun. Because I want to know.
All right, let's go. Sinus block means SA node is firing, but impulses are not leaving. Arrest means that the inherent rate of the SA node is not working. It's not able to do what it normally do. It's not able to generate impulse. Okay. In block, it's able to generate the impulse, but it's not getting out. Exactly. Say again.
It's not getting into AV.
Exactly. It's not leaving it to even depolarize the A cell, but it will get to the AV nodes. Yeah. All right. I have a lot of slides. Next, so I'm going to go kind of fast pace. But I still want you guys to help me. Actually, I like to give this in 2 lectures, but we don't have that kind of luxury. So I'll do my best. You've seen this slide before. It's just again to talk about the autonomic influence on the SA node. And these are the causes of tachycardia. You've seen this slide. This is the 3rd time you're seeing this slide talking about the causes of sinus tachycardia. Okay? And all of this, you don't need anybody to tell you. Somebody is febrile, their heart rate will be higher. Somebody is anxious, somebody is exercising, all of that. There are medications that will make you go. What you want to find out when somebody has tachycardia is arrhythmias. You want to make sure that tachycardia is not due to an arrhythmia. So that's what the next thing is going to be about. So this is sinus tachycardia. This is SA node responding to any of those conditions: anxiety, stress, caffeine, exercise, heart failure, whatever it is. The way you know it's sinus tachycardia, you always have PQRS all the way. The rate is regular. The rhythm is regular, sorry. Rate is usually above 100. Rhythm is regular. There is a P wave before each QRS, and all the P waves are identical. Now you know why that is important, because we've talked about multifocal atrial tachycardia, we talked about wandering pacemaker. You understand why it is important for every P wave to be identical in that rhythm strip. And PR interval is normal and constant, QRS less than 3 small boxes. Okay, now, there are times when the SA node is working properly But some ectopic focus got this new energy and is able to beat the SA node and compete for dominance. That is what I call enhanced atrial automaticity foci. So you have a foci, a focus, plural is foci, that gained enhanced inherent rate that is now trying to compete with a normal SA node. Remember before we had the escape rhythm because the SA node loses dominant. So a weak SA node can definitely lose to other competing pacemakers. But in this case, the SA node is normal. But there is a foci or a focus that gained energy and will compete with the SA node. So when that happens, you get what is called, depending on where it comes from, it could be, the focus could be in the atria, or it could be in the ventricle, or it could be in the junction. Bottom line is, the inherent automaticity of that focus is enhanced and is able to compete with a normal SA node. So that is what is happening here. So you see an SA node, rate here is about 1, 2, 3, 4, about 75, that's normal, right? And the SA node is doing its thing, PR interval is fine, everything is good. Then what the heck is this? Where did this come from? This complex came. He has this P wave, and it just came earlier than it should. You need to recognize this as a premature atrial complex or contraction. It comes and it goes away, and the SA node continues. The way you know is an atrial complex is the P wave is always different. Okay? That's how you know a PAC. It becomes clear as we go along. So this is where it comes. So premature means it comes earlier. Okay? It comes earlier than it should come. Right? So this is your normal SA node, normal. You see how close it is in configuration? And then you see this one. This one is not right. That configuration of the P wave is not normal, right? You all agree with that, right? So that is what makes it a premature atrial contraction. Now, it is premature because it came earlier. Now, remember in the earlier lecture, when we're talking about the electrical activity of the heart, and I talked about absolute refractory period and relative refractory period. When a premature contraction comes early and hits the ventricle, when the ventricle is in absolute refractory period, what the ventricle does is just shun it. It won't be conducted. So it will be a blocked contraction. So you will see this weird P wave and it will be by itself. How would you tell that P wave from a second degree AV block? The configuration. Okay? There are times the P wave premature contraction will come up. It will come up so early that it will hit the ventricle when the ventricle is in its own refractory period. When it meets the ventricle in its relative refractory period, it may be conducted, but it will have what is called abnormal conduction. We call it aberrant conduction. So you can see a premature complex, that will be PAC, that will have an aberrant conduction. I'm just setting the groundwork for what you're about to see. Okay? So you understand the concept. It becomes prematurely, it can catch the ventricle when the ventricle is in absolute refractory period and it will be blocked. Or you can catch the ventricle when the ventricle is in its relative refractory period and it will be conducted, though abnormal. We call it aberrant conduction. Or you could catch the ventricle when the ventricle is actually ready to receive the impulse and it will be conducted like a normal pulse. Okay. So here it's what you have. See, This is a normal PQRS sinus wave, right? You see this P wave right here? Does it look like this P wave? No, it's not, right? So that P wave did not come from the SA node, right? And this P wave is followed by this QRS. This QRS and this QRS, are they the same?
No.
This QRS has a right bundle branch pattern, right? Because remember, this is V1, right? An RSR pattern in V1 is highly suggestive of a right bundle branch block, right? So this is what you will call a premature atrial contraction with aberrant conduction. The aberrancy in this case is a right bundle branch pattern. Okay? And you see, it is not by itself. This is sinus beat. This is a PAC with aberrant conduction. This is sinus beat. This is sinus beat. This is a PAC coming from the same place and arriving in the ventricle at exactly the same time in such a way that the aberrancy is the same. Okay? So here is premature atrial contraction with aberrant conduction. So the right bundle branch conduction pattern means that the right bundle was not ready for the premature contraction. Okay? You all with me? Okay.
I didn't catch what you said about the gift right there that has left in the arrow.
This one?
No, that one. Yeah.
Yeah, this is the QRS that represent the ventricular depolarization initiated by this P wave. It's the normal one. Here is a premature atrial contraction. It initiates a ventricular depolarization that is different from this one, because this premature contraction arrived at the ventricle in its relative refractory period when the ventricle was not really ready. So the conduction did not go well. He went with this abnormality, and abnormal conduction typically is defined as aberrant conduction. Okay, so this is a PAC with aberrant conduction, and the specific aberrancy in this case is the right bundle branch pattern, because this is V1. Remember when you see RSR, this is an RSR pattern, right? Whenever you see RSR pattern in V1, that's a right bundle. In V6, it's left bundle, right? You remember that?
Yes.
Okay. Please, I have to make this call. This is somebody that hey, Greta, good morning. Please don't leave. No, don't leave. Well, I'm going. Where are you exactly? Could you go back to the provost office? I will send somebody to pick you from there and take you to Lindsay. Thank you. Thank you. Okay. Hey, Holly, Greta is in the provost office. Go get her from there and bring her to the department. Yeah, okay, thank you. Yeah, okay. All right. So, you're all clear with this, right? Excellent. So look at this. Here is a PAC, but it didn't get conducted. But it's not a premature atrial contractions can also be blocked by the AV node if it arrives too early. This particular one here It's actually a PAC, believe it or not. But it looks more like a PAC over here, right? It's premature and it was not followed by a QRS. That is what makes it a blocked PAC. I have a better example down the road. Now, we just talked about premature atrial contractions. Okay? You know what they are. They are P waves that come earlier than they should. They could present in three ways. It could be blocked, in which case it is not followed by QRS. Or it could be conducted normally, in which case it is followed by a QRS, a normal QRS. And the only way you would differentiate it as a PAC is because the configuration of the P wave would be very different. And finally, it could be conducted with aberrancy. So the following QRS will be abnormal, and the pattern of that aberrancy will reflect what the abnormality is. Most of the time, the QRS will have an RSR, a bundle branch pattern, depending on which lead is used for your rhythm strip. So you remember that a PAC will come with a P wave. That is what it is. But how it gets conducted depending on how premature it is. If it's too premature, it will be blocked by the heavy load. If it meets the ventricle in the absolute refractory period, it will not be conducted, it will still be blocked. If it meets the ventricle, arrives at the ventricle in the relative refractory period, it will be conducted with aberrancy. Okay? Now, there are times a PAC, a premature atrial complex, will couple with a normal sinus rhythm. In other words, there is the SA node taking control, and then there is this enhanced site that feels I can do it too. Instead of competing, they now kind of like enter into an agreement almost. It's like the SA node will say, okay, no, I want to stay in charge, but I'll let you take charge. Maybe you deliver every other beat. So you find a rhythm where the SA node delivers, and then this side delivers, the SA node delivers, this side delivers, the SA node, this side. Whenever you have a premature atrial contraction that are coupled to normal sinus rhythm, giving you group beating like this is what is called the geminal rhythm. And depending on the agreement, if it's every other beat, you call it atrial bigeminy. If it's every third beat, you call it atrial trigeminy. Why do you think this happens? The reason this happens is because the ectopic site wants to ensure that it gets to the ventricle. It doesn't want to be blocked. It doesn't want to arrive at the ventricle when the ventricle is in the absolute refractory period. It doesn't want to have an aberrant conduction. It wants to be conducted normally. And in order to do that, it has to work out something with the SA node in such a way that it will deliver its own impulse at a time after the SA node when the ventricles are receptive. So when that happens, you get this group beating. You get a PAC that is alternating with normal sinus node, or comes every other beat. So this is sinus, sinus, PAC, sinus, sinus, PAC. The only difference, how do you know this is a PAC? Because the P wave is different. It's different. And it's similar to this, so it's coming from the same place. You got that? Are you all with me?
Yes.
Okay. Remember how an escape focus will take over and becomes an escape rhythm? Right? The same way, a premature focus can take over and be the dominant rhythm. When that happens, as in this case, you see this sinus beat, sinus beat, sinus beat. What the heck happened here? Something happened here, and it took over. Whenever this happens, we call it a paroxysmal tachycardia. It's coming from the atria. And you may ask me, how do I know it's coming from the atria? This is a normal SA node beat, a normal SA node beat, a normal SA node beat. And here is this rhythm right here. Do you think it's coming? Does this look convincingly like it's coming from the atria? Yes or no?
Yeah.
No, right? Anybody say yes? It's no, because how would you have known? You needed to have seen a P wave that is different from the other P wave to know that this is a PAC that took over. But there is no P wave here. But I couldn't find a strip that showed the transition. Right? And whenever you see this, this is an atrial ectopic bit that started right here, and it was not coupling with the SA node, but it actually took over. Whenever this happens, it usually happens suddenly. And it is called paroxysmal because it happens suddenly. It comes in paroxysms, atrial tachycardia. And you notice that here it is called a sudden onset SVT. Supraventricular tachycardia means this strip does not really tell you whether it came from the junction or it came from the atria. Okay? That's why it's called SVT. I'm using this strip to illustrate paroxysmal atrial tachycardia. Under normal circumstances, an paroxysmal atrial tachycardia will have a P wave that will be different from the other P waves. That's how you know that this is an atrial ectopic that came up and took over the pacemaking of the heart and put the heart into a tachycardic range. Yes?
Can you repeat that? I missed that.
Repeat what?
What?
I'm saying, first of all, I'm apologizing for this strip because I couldn't find a strip that actually has a P wave in front of it. An ideal strip will have a P wave here that will be different from these preceding P waves. That is what will clue you in that this focus is from the atria. And because he now took it upon itself and established itself as the dominant rhythm, and it's tachycardic, and it started suddenly, you will call it PAT, paroxysmal atrial tachycardia. Okay? And I say, look at the title they gave this script. They gave this strip the title SVT because it does not really look like an ideal atrial tachycardia, because an ideal atrial tachycardia will have a P wave right there. Depending on how fast the rate is, the subsequent P wave can merge with the T wave and may not be visible, but the first one should have a P wave. Okay? So just remember when I said how the escape repeat becomes an escape rhythm. This is PAT, is a PAC, a premature atrial contraction, now establishing itself as the dominant rhythm. Okay? In exam, I would always show you the transition, either at the beginning or at the end. You would always see the takeover or the relief. So in order for you to call it paroxysmal, anything, you have to see the onset or the end. You don't see both, you see one. In this case, onset is visible. All right? All right, so look at what is called, remember that PAT rate is what? 150 to 250. Okay, that is the rate. Sinus tachycardia rate is what? 100 to 150. Paroxysmal atrial tachycardia rate is 150 to 250. Okay, now, atrial flutter. Atrial flutter is when that abnormal focus, again, goes crazy. Crazy as in, you just now go from 150 to 250, started going at 250 to 350. So the difference between paroxysmal atrial tachycardia and atrial flutter is in the rate. But when you look at atrial flutter, because the rate is so fast, the AV node cannot conduct everything. Okay? The AV node cannot conduct every P wave it gets. Okay? So you have excess P waves. So it looks like you have an AV block, but it is really a physiological block. The AV node is not diseased, but the impulses are too crazy fast that it doesn't conduct it through. There is a reason that happens, and it's a good reason. Think about it. If all of the impulse arriving at 350 go through the ventricle, where is the time for diastolic filling? Patient will go into shock immediately. But because of this physiologic block, the ventricular response does not always go at the same rate as the atrial response. So whenever you see this excess P wave, because they all come from the same place, the P configuration is normal. The P configuration is identical, but it's excessive. So you will see like 4 P waves, the same P waves before the QRS. And because the P waves are identical, it gives you what is called the sawtooth appearance. So you see this sawtooth appearance. Whenever you see multiple P waves between the QRS and the sawtooth appearance, that is the definition, that is the way, the configuration of atrial flutter. And you confirm it by the rate. Remember, the rate that we're talking about here is not the QRS rate, it's the atrial rate. Okay? Remember that. Right? The atrial rate is what we're talking about. And when you see the rate where you can see 2 P waves within one big box, that rate is over 300 already. If it is only 1 P wave, one big box between 2 P waves, that is at least 300. So if you can see 2 within less than a box, a big box, like you see these 2 P waves occupying less than a box, and these 2 P waves right on the box, whenever you see the rate, the number of, to see 2 P waves within about a box, that is giving you the impression that this rate is at least 300. That is the rate range for atrial flutter. So how do you identify atrial flutter? You have flutter waves. What do they look like? They look like sawtooths. Okay? Sawtooth. Sawtooth.
Shark tooth.
Sawtooth.
That works too, though.
It's like a saw. Sawtooth. Right? So that sawtooth appearance is what we call the flutter wave, okay? More important, yes?
So in this case, when we're counting the heart rate, we're not counting the boxes in between the QRS complexes?
You're actually, not QRS, P wave. Yeah, exactly. That's why I said, you remember, we're talking about atrial rate and ventricular rate. So, the atrial rate is what you want to look at. When it's coming after every big box, Martin and Christian, I will send you out. When it's coming after every big box, that is at least 300. Okay. When you're finding 2 P waves within one big box, that is over 300. Okay. That was I was trying to make the point that look, before now we used to compute the rate with QRS, but when the atrial rate is crazy and you are beginning to carry excess P waves, you want to really determine the atrial rate. The rate I'm giving you here for definitions are atrial rate, not QRS rates. Okay? Excellent. So, sawtooth, 250 to 350 atrial flutter. Okay? Under normal circumstances, whenever an ectopic focus discharges, it will normally depolarize the other ectopic focus and take over. So basically, when there are multiple foci that are competing for dominance, they submit to themselves. But when you have these abnormal situations that are called parasystolic atrial ectopic focus, these are ectopic foci that don't submit to themselves, they compete with themselves. Okay? Remember the multifocal atrial tachycardia we talked about? It is because of those parasystolic atrial focus. Like, see this one? Everybody knows what this is, right? This is multifocal atrial tachycardia. Right? You remember this? Why is this multifocal atrial tachycardia? Because one is tachycardic, two, the P waves are different, and you can make out at least 3 different P waves. Right?
Yes.
You are with me? This P wave is not the same as this P wave. This P wave and this P wave are the same. This one and this one is the same. This one is not quite the same as this, but it looks like it might be the same as this. This P wave is not the same as this, nor this. Right? So when you look at this rhythm, you could figure out at least 3 different P waves. Right? 3 different P waves, tachycardic rate, M5, multifocal atrial tachycardia. If the rate was normal, it would have been a wandering pacemaker. You remember that?
Yeah.
Okay, good.
So for,
Yeah.
so for this one and for the multifocal for the PAT, are you saying we use the atrial rate? No.
It does not matter here because to every P there's a QRS. And it is always easier to use the QRS to determine the rate. For as long as there is a QRS to every P, you don't need to worry. You can use the easier one, the QRS. But when there are multiple P waves before the QRS and you're trying to determine the rate, you have to use the P rate. You have to use the P wave. You got it? When it's 1-to-1, it does not matter which one you use. Okay? I remember when we were talking about the rate of the heart, I told you that if the rate is irregular, you're better off counting for a longer span, 6 seconds preferably, right? Remember that? This is one place you do that. But is there anyone in this class that does not recognize this as multifocal atrial tachycardia? You all can identify at least 3 different P waves on this strip, right? Excellent, okay. Huh? I just skip a slide? The one before it. Now, I was just using it to explain to you why you have multifocal atrial tachycardia.
Oh, that one?
Yeah, this one. I'm telling you the reason you could have multifocal atrial tachycardia is because of the existence of parasystolic atrial ectopy. So, under normal circumstances, all the other pacemakers, they submit to the SA node. So when the SA node impulse arrives, they pack up and they depolarize. But when you have multiple foci trying to pace the heart at the same time, and they are not submitting to themselves, they are called parasystolic. Everybody is insisting on his own rate. That is this slide here is just telling you that is the pathophysiologic basis for the multifocal atrial tachycardia. Because the reason you have multifocal atrial tachycardia is because of this parasystolic atrial ectopic foci. Okay? Now, whenever you look at a strip and you cannot really figure out a P wave, and you see only undulation of the baseline followed by irregular QRS complexes, that is what is called atrial fibrillation. You see, the reason you could see P wave is because at least some atrial fibers are contracting together, and their energy, their electrical energy, is adding up to give you a P wave. The P wave might vary, but at least they are working together. When the atrial fibers are now working on their own, then none of them is working together. They're all doing their own systole at their own rate. In fact, when you look at the picture of the atrium in fibrillation, it looks like a bag of worm. And when you do other means to calculate the rate is usually over 350. So look at this strip, for instance. Can you tell P wave? Can you tell the P wave from here? All you have is a gentle undulation of the baseline. Whenever you have a gentle undulation of baseline without visible P wave, and you have irregular ventricular response, that is the definition of atrial fibrillation. Okay? And this is just an example of what it looks like. Atrial fibrillation and atrial flutter, many times they coexist. So, a patient can present with atrial flutter, and in the emergency room, right there and then, under your nose, degenerate into atrial fibrillation. The backwards is never the case. They get worse. Flutter to fibrillation. And we used to make a joke, call it flubber. When you go from flutter to fibrillation, say the patient is in flubber. There's nothing like that. It's just some ER docs do that all the time. So this is just telling you how the atria is looking in atrial fibrillation and flutter. It's just discharging impulses. The good thing is that most of the impulses will be blocked by the AV node. Because think about it, if every impulse is conducted, the ventricles will be driven at over 350 rate per minute. That is not a good thing, because that means there is no time for diastolic filling. You will compromise cardiac output. You will compromise circulation. Okay? This is talking about the treatments, but we're not going to talk about treatment right now. So look at this. The top script, you see how crazy it looks? You really cannot tell what is P or what is not. And look at the sawtooth appearance of flutter. So the top is fibrillation, the bottom is flutter. One thing you must pay attention to is atrial flutter is a regular rhythm. You can see the P waves. And the conduction rate can go from anywhere from 2 to 1 to 4 to 1. So you get in both of them there is irregularity, but there is a little bit of a pattern to the irregularity of atrial flutter versus AFib. In atrial flutter, it's a regular irregularity, whereas in atrial fibrillation, it's an irregular irregularity. Okay? Are you with me? I kind of think that I should complete. There's no class next Monday, right? But the next class is syncope. So I think I'm going to do just a couple of more slides and stop so that you guys can go and digest this one, because I think you're already looking like tired, and I want you to, this is important. You can't afford not to understand this. Okay? So this is the difference between AFib and A-flutter. The difference is, number one, in atrial flutter, you have discernible multiple P waves. The AV node does not conduct all of them. It could conduct 2 to 1, 4 to 1. So that creates a regular irregularity in the QRS. Whereas in AFib, the ventricular response is irregularly irregular. How do you tell them apart from the bedside? How do you diagnose AFib without EKG? Pulse. So the pulse in AFib is irregularly irregular. That's number one. But the pulse will be irregularly irregular if you have multiple ectopics. Pulse will be irregularly irregular if you have variable AV block in A-flutter. So how do you really tell the difference? The way you tell the difference is you take the pulse in the radial and you count the beat from the heart. if the difference that is called pulse deficit is more than 10, your patient has AFib. If the difference is less than 10, your patient has no AFib. It could be flutter, it could be anything else. And there is a reason that is the case. Because in AFib, the atria is firing upwards of 350, and ventricles is responding as hard as they can. So there is variable diastolic filling time. Because there is variable diastolic filling time, the cardiac output varies from beat to beat. Some of the cardiac output will not elicit a peripheral pulse, but they will still produce a heart sound. So if you count the pulse from a heart sound, it will be the most accurate. And you feel the pulse, count the pulse from the radio, it will be less accurate. And the difference will be more than 10. And that difference is called pulse deficit, something you can use. It's a clinical problem.
So it's less than 10?
The difference, when the difference is less than 10, it's not AFib. It could be a bunch of other stuff. But AFib is usually irregular pulse with a pulse deficit greater than 10. All right. Remember Wolff-Parkinson-White? Wolff-Parkinson-White has an abnormal communication between the atria and the ventricle. Remember that? We call it the aberrant bundle. Bundle of what? Bundle of Kent. Right? There are two ways Wolff-Parkinson-White can present. Depending on how the re-entry is set up. So in Wolff-Parkinson-White, you have what is called a re-entry mechanism that involves the SA node, the Purkinje fibers, the ventricular tissue, and the accessory pathway. So this is the accessory pathway here. 90% of the time, the atrial impulse goes down the AV node through the bundle of His to the bundle branches, and is supposed to only depolarize the ventricles. But because there is this abnormal communication between the ventricle and the atria, that abnormal communication conducts that same impulse and gives it back to the atria. And then the impulse now re-enters the AV node and keeps doing that. That's what we call it, re-entry. So the AV node is getting impulse not only from the SA node, but is also getting it from its own ventricle through this aberrant pathway. So that is what is called re-entry mechanism, when the impulse gets recycled between the atria and the ventricle without involving the SA node. You got that? This is what happens 90% of the time. When the impulse goes down the AV node, like it would normally go down, we call it orthodromic conduction. That's what we find 90% of the time. When that is the case, the QRS complex is usually narrow because it's coming down the regular pathway, right? 10% of the time, it is the opposite. The impulse goes to the ventricle through the aberrant pathway and now uses the bundle branch to conduct the impulse back up to the atria and set up the cycle like this. And because the impulse is traveling in the opposite direction through the AV node, it is called antidromic pathway. When that is the case, the QRS complex is usually very wide. Okay? Remember, I told you that impulses don't travel from the ventricle up the bundle branches and the AV node. No, they don't. But they can travel up from the bundle branch. because that is electrical tissue, right? Idioventricular rhythms don't go and depolarize the atrium, they don't. That does not happen. But in Wolff-Parkinson-White, the impulse will go back up through the bundle branches and recycle like this. So the reentry is like that. Why is it important to make the distinction between these two? If somebody has this, and you give them a calcium channel blocker, you will convert that to this. That is why, anyway, they will tell you more about that in the ACLS. Just all I want you to know now is that yes, Wolff-Parkinson-White is due to the presence of an aberrant pathway. There are two types. It could be orthodromic or antidromic. It is orthodromic if the ventricles get depolarized through the AV node. It is antidromic if the ventricles get depolarized through the aberrant pathway. In both of them, there is reentry. Okay? And in orthodromic, the QRS tends to be narrow. In antidromic, it tends to be wide. Good. So that is just all I want you to know for now about Wolff-Parkinson-White. So now, let's talk about, we'll still continue with this enhanced automaticity. So we have an enhanced automatic focus in the junction. So you're going to get a JPC, a PJC actually, is premature junctional complex, right? If it comes from the atria, you call it premature atrial complex. If it comes from the junction, you call it premature junctional complex. If it comes from the ventricle, you call it premature ventricular complex. So see what happens. I already explained this to you. There is a normal SA node beat. Normal SA node beat. What the heck is this? It doesn't have a P wave, so it's coming from the junction, right? It's not from the ventricle because it's narrow. So it's a junctional complex. Right here is a junctional complex. Is it high or low junction? Is it high or low junction? Where did this come from? Low junction, right? It's low junction because you see the P wave, right? Coming after it and it's inverted. Right? You got that? So this is a high junction, a low junction PJC, okay? With retrograde depression. We're going to talk about this.
Dr. Martins,
Yeah.
is it the Wolff-Parkinson-White? When you talked about left axis and right axis deviation, why did you make a distinction of one is caused by the left and one is caused
Wait,
by the
in
right?
Wolff-Parkinson-White?
Yes.
I didn't talk about right axis or left axis.
When you were talking, the first lecture, when you talked about causes of left axis deviation, causes of right axis deviation. So you mentioned Wolff-Parkinson-White, and you said one is right reentry and one is left reentry. So why is that distinction there?
Okay. You're going to complicate this subject, but I will answer it the simplest way I can. In Wolff-Parkinson-White, there is an aberrant bundle that is connecting the atria to the ventricle. Okay? If the connection is between the right atrium and the right ventricle, right, that will give you a left bundle branch pattern. If the aberrant connection is between the left atrium and the left ventricle, it will give you a right bundle branch pattern. on the EKG, but that's a totally different subject. In this case, I'm giving you how Wolff-Parkinson-White results in arrhythmia. Wolff-Parkinson-White goes into arrhythmias, tachyarrhythmias. That is when they get sick. Otherwise, you just see delta wave and a short PR interval. That's it. But that person with a short PR interval and a delta wave is at risk for some serious arrhythmias. And the way the arrhythmias happen is because of these re-entry mechanisms. And it could be autodromic. If it goes down the AV node and goes back up through the aberrant pathway, it does not matter whether it's on the right or on the left side. It does not matter. What matters is that it gets conducted back through the atria and recycles down the AV node and keeps depolarizing the ventricles. And because it comes down the AV node, it gives you narrow QRS complexes. And on the antidromic variety, it uses the accessory pathway to come down and goes back up through the AV node. And because it comes down through the accessory pathway, the QRS tends to be wide. Okay. So this is your PJC. Everybody recognize this as a junctional beat, right? Excellent. Sometimes PJC can couple to the normal sinus rhythm, just like PAC. You still call them bigeminal rhythm, right? So this is an example of a junctional rhythm coupled to a PAC, coupled to a PJC coupled to normal sinus, right? You recognize this. So look at that QRS. Is it wide or normal? It's normal, right? It's about 3 small boxes, right? Okay, but it looks wide. If you don't count boxes, it looks wide. So always make sure you count the boxes, okay? And then see what happens. What do you think this is? This is an exception to what I told you earlier. I will never give you this in an exam. But this is a paroxysmal junctional tachycardia, where a junction just took over the rhythm. I didn't show you the onset here, but see what has happened. These are all P waves, right? When that escaped junction, PJC becomes a junctional rhythm and it's tachycardic. You see this? These are all what we call a PJC earlier is this one, but it has become the dominant rhythm, right? So when that is the case, it's called a paroxysmal junctional tachycardia because it's a fast rhythm. If you look at it, this is like what? 2.5, thereabout. So it's a little over 100, right? Right? If the rate was normal, you would call it junctional rhythm, right? Say if the rate was, say the rate was, say, 50, and this is what you have. You call it a junctional rhythm. You call it junctional tachycardia not because the rate is high, okay? Remember, always make a decision on the rhythm and on the rate. Validate your rate impression with the rhythm and your rhythm impression with the rate. Always use both of them together, okay? Are you with me? The same thing that can happen to PAC can happen to a PJC. A PJC can get blocked, okay? So this is a junctional beat. Blocked, conducted, 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 blocked. I'm going to stop here. I'm going to stop here because we're out of time and you guys look tired. But before I leave, are you all clear on PACs, how it can be blocked, how it can be conducted normally or conducted abnormally? What makes the PAC what it comes earlier than it should? But its fate depends on its timing. It could be blocked, it could be conducted normally or conducted abnormally. when it is conducted abnormally, it's called aberrant conduction. And the same thing happens with junctional PJC, premature junctional complex. The difference between a junctional complex and an atrial complex is in the P wave. P wave is usually not in front of a junctional complex. When you say a complex that is narrow and doesn't have a P wave in front of it, it's a junctional complex. If it's coming from high in the junction, you will never see the P wave. But if it's coming from low in the junction, you might see the P wave after it, and usually it will be inverted. When that premature complex, whether it's a junctional or atrial complex, starts and takes over the rhythm, it becomes paroxysmal atrial tachycardia or paroxysmal junctional tachycardia. And by definition, normal heart rate is 60 to 100. It is paroxysmal atrial tachycardia when it is between 100 and 150. It is atrial flutter when it is between 150 and 250. It is atrial 150 and 250. It is atrial, what am I saying? It's normal when it is 60 to 100. It's sinus tachycardia when it is 100 to 150. It is paroxysmal atrial tachycardia when it is 150 to 250. It is atrial flutter when it is between 250 and 350. It is atrial fibrillation when it is more than 350. Okay, so from the rate alone, you can have an idea. If the rate is already 350, that is in the fibrillation range. So you now just go to look for atrial fibrillation, regular QRS complexes and stuff like that. If the rate is 140, that is in sinus tachycardia range. So you expect to have PQRST in front of everything, right? If the rate is 250, then you know that is in the range of paroxysmal atrial tachycardia, right? And then you just validate that impression with your reading. So rate and reading disorders are separate from EKG disorders. Don't confuse them now. Now is when I need you to forget everything about EKG and just focus on the rhythm. Don't think axis, don't think anything. Just think rhythm, think rate, think rhythm. And make sure you're able to understand why things may look the way they look. Before we go to the syncope lecture next week, week after next, I will finish this reading stuff. Before then, please, it will do you a lot of good if you can just go over everything we talked about today, so that when I'm talking about syncope, when I finish the lecture next week and we'll go through some exercise, I start talking about syncope, you understand everything else that we didn't talk about, okay? Yes, yes.
Just those ones?
No, this one, the junctional tachycardia, I didn't. Yeah, I couldn't find anyone that has